Our last speaker to round out the conference today is Dr. Daniel Corsi. He's an assistant professor and an epidemiologist at the University of Ottawa. His work has already been quoted a few times in the presentations that you've heard. He focuses a lot of his efforts on looking at maternal substance use during pregnancy and the implications for child development. You've heard about the Born study. He's also leading a large prospective cohort called the Cupid study, which is looking at the impact of maternal use of cannabis and ultimate long-term developmental outcomes for the child. So please join me in welcoming our final speaker of the day.
Great. Thanks very much. Pleasure to be here. So hopefully I'll get the slide deck to advance. Okay, excellent. So yeah, my talk is on cannabis use in pregnancy, socioeconomic status, perinatal outcomes, and neurodevelopment in offspring. And thanks to all the previous speakers, it's been a real pleasure learning about your work, and you've set everything up nicely for me. So why study cannabis use in pregnancy? I'm an epidemiologist. I have a real interest in substance use, tobacco use. I've been looking at trends in cannabis and other things for many years. And so there's a big interest in the question now. So I'm happy to be a part of that. So this is an older survey, I guess, from the American College of Obstetricians and Gynecologists, but in their data found a majority of women sort of felt that there was, a slight or no risk from using cannabis, infrequently in pregnancy. And we heard this before, there's kind of anecdotal evidence that it may be organic, natural, vegan, can help you with morning sickness and other ailments in pregnancy. Actually, a student of mine put this together. I got two slides going, so I gotta keep up with myself. This is the trends in just general population cannabis use over time in Canada, and we compiled a few different national surveys from 2002 to 2019. So we can see there's some pretty marked increases in recent years, but interestingly, some of the trends had been increasing even before legalization, so since 2012 or there around that time. Okay, so, and we heard a little bit about this, how the perinatal period is very unique, and that's why we focus here. Development can be, it's ongoing from preconception onward, pregnancy, and early childhood. I think one parallel example that some of my colleagues use in Ottawa is on fetal alcohol syndrome. So just our understanding of this has some important lessons for cannabis, that exposure to certain things like alcohol in pregnancy, while it may not be harmful to the mother, can have lasting impacts on the fetus, and exposure to substances can affect different developmental processes. Central nervous system can be vulnerable to insults from substances, and there may be things that aren't evident immediately at birth but may manifest later. So just a kind of a quick summary. I know we talked a lot about the epidemiology already, but it's pretty common nowadays to have cannabis in pregnancy. The rate is variable. There's issues around reporting, but it's frequently used together with other things like tobacco, alcohol. 30% of individuals with fetal alcohol spectrum disorder also had cannabis use. There's complex relationships, therefore, with other substances. And the timing of use may have impact for fetal development. Some outcomes we've identified in the Ontario data are associated with cannabis were preterm delivery, low birth weight, but there's conflicting data on whether other things like anomalies or stillbirth is also associated. I mean, some things like a rare outcome like stillbirth, there's not great data on there, even in Born, which is a big database. And the neurodevelopment question is still unanswered. So unfortunately, I'm the last speaker, but I don't know if I'll be able to answer everything today, but I'll do my best. So here's just some more of the data on cannabis use trends. And here I've split this by age. So it's really important to note that if we take a average figure like 2-4%, if you unpack that by certain factors like age, you're going to see a big variation. Like we can show over 10% consumption in 15 to 19 years women, and that's reported. I mean, that's sort of in born, it's a mixture of reporting, disclosed to the physician, and being screened for that. Whereas in older ages, it's a bit more stable. This is the data by income, which is, we don't have great socioeconomic status data in porn, so we use a combination of area level measures from postal codes to look at income, postal code income. But we can see a gradient where the usage increases with lower area level income measures. So for the audience, if you haven't heard about Born, it's Ontario's birth registry. It's a big database now with 1.3 million records. So the sort of current iteration launched in 2012, and it just gets continuously added to. So it's pretty amazing resource. I mean, we didn't really realize at the time, but it's basically one of the biggest databases on cannabis use and pregnancy, because within the data they're collecting the cannabis use. And the team at Born has also, expanded that a little bit. So they've augmented some of the questions to have specific field for cannabis use to get better data. I'm going to the laptop here. Here's a slide on Born. Some more data on the demographics. So, which was interesting when I kind of split it by year. Initially in 2012, the majority of users were in the youngest ages, but that over time it's kind of expanded to all ages. This was the pre-legalization cohort, 10,700 individuals. Women with lower income reported higher use, as we mentioned. And here's some data on the pregnancy, cannabis use in pregnancy and outcomes. So for no use, I kind of lost the legend when I was doing the slides, but I put a little heading so that no use is on the left bars. So something like 7% on average is the rate of preterm birth in Ontario, and it was 10% in cannabis users. But there's a real concern of confounding here. We did a lot of efforts. The reviewers are really concerned about that, so we adjusted for many things. We stratified by cannabis only to remove other substances like tobacco, alcohol, and a lot of the effects persisted, but sometimes it's impossible to remove the confounding completely. And similarly for neurodevelopment, we looked at 3 outcomes using the ICS data, and those have some caveats and limitations, but we can kind of formulate some algorithms to look at autism diagnosis and neurodevelopmental conditions and ADHD in these data. And we do see a signal with use of cannabis and these outcomes, and then through successive adjustment for things, it kind of attenuates, but it wasn't completely removed for autism. So discussing a little bit more about cannabis pregnancy and the fetus. So cannabis consumption and its potential impact on fertility and pregnancy outcome is recognized, and that's a testament to our speakers today. The THC can cross the placenta, accumulate in fetal tissue and maternal milk. So it's a very interesting area to explore. Why do we care, and where do we go from here? So this is a real passion of mine for my own research, and I'd like to situate this research within the prenatal environment more generally, which can affect child outcomes throughout infancy and early childhood as a critical developmental stage where the brain architecture is formed, genetic expression, caregiver attachment. So it's not just in isolation what's the effect of cannabis, but it's the whole picture here and using a life course approach, highlighting cumulative risk over time. So, but there's many challenges in this area, and to identify a conclusive relationship between cannabis use and pregnancy or with child development outcomes is really difficult because you have so many things going on, and this is part of our sort of ongoing work where we've launched a team grant on cannabis use and pregnancy, and these are sort of the laundry list of limitations of research, and it's already been touched upon today, but we have many exposures at the same time. There's a social determinants issue, which is very huge and I think underappreciated. We do have limits to how we collect the data, and there is ongoing stigma and difficulties in disclosing this consumption to providers, and providers aren't able to initiate the conversation either because they have limitations in what they feel comfortable with and their knowledge. And I seriously doubt we'll see any RCTs in this area, but I guess it could be possible in certain specific settings. But our objective is sort of to curate as much data as we can, bring it together, use different lines of evidence to form more robust evidence and conclusions. So I'll highlight a few things kind of in the works, but still much to be done, but we have a few kind of interesting, exciting things happening. So I think we kind of, Allison sort of touched upon this, but a lot of this, I do have an animation actually. So a lot of the data to date were based on a few studies that weren't really that high quality, and it's summarized in a report here, which you can cite, but there's basically 3 kind of prospective studies to date that look at this question. We have a kind of a pseudo cohort that we set up with the born data and then the ICS data, so it kind of, we can trace somewhat the individuals over time, but there's some limitations there. If you don't access health services, then it's not actually linked fully. But there's a few ongoing cohorts, and kind of a schematic of the life course approach. So what we can do with the existing data right now, we have Born Ontario, which gives pretty good data on cannabis use reported and disclosed to providers, and we have some data on socioeconomic profiles based on geography and good clinical data on obstetrical and medical history. And then using those data, we can take them to other provincial repositories for other studies. And we're working now to link with the EDI, which is the Early Development Instrument. Some of you may be familiar with that. It was developed here at McMaster. There's some issues, though, with actually linking the data, but I'm told that it may happen at some point in the next upcoming while. And it has a couple nice advantages because it's a population-based metric, so it's administered to children in kindergarten around 5 years of age, and it's a well-validated instrument and has different domains to assess child development and school readiness. So the plan is to actually link that with Born and kind of explore how cannabis use may influence those developmental domains. And another kind of interesting feature of the EDI is that it's used in other jurisdictions, both in Canada and internationally. So we're working with partners in BC, Nova Scotia, maybe Manitoba as well, where they have all the data to sort of put that together. Unfortunately, Ontario has probably been the hardest to work with. Nova Scotia has also been difficult just because there's a lot of legal issues around the linking. So we've got BC kind of going, and we're exploring that right now. The way it works is that we'll just look at the scores because the EDI is kind of a continuous measure. And then there's a way that there's different kind of analytical approaches that we sort of propose, looking at sex-specific effects, looking at what's called vulnerability, so lowest 10th percentile in those different domains. We also are working with the ALSPEC cohort, which is a sorry, my animation didn't catch up. This one doesn't have the animation. So there's some more data about that. So we can assess the variability across subgroups using the 10th percentile cutoff. And this is the data on the ALSPEC. So we also found that in the UK, the ALSPEC cohort, 15,600 participants. They recruited in 1990 to 92 in Avon, UK. And it's an amazing cohort. I mean, they've continuously followed up the cohort for 30 years, and there's still tons of research coming out of it. But they have the father's cannabis use as well. So we kind of looked at that, looked at some linked data. They have the GCSE, which is educational testing score, and we looked at cannabis use, higher frequency use, so weekly use had associated with lower GCSE scores, and that's at age 15, I believe. And we're using what's called a maternal-paternal comparative approach. So we use the father's cannabis data and associate that with the outcomes as well to compare the strength of the association as a way of understanding if the causal mechanisms. And you mentioned in the introduction, so we have the Cupid. It's not a large study yet. It's a pilot study, but we're hopefully going to establish this as a feasible project and then sort of expand to other sites. We have Ottawa right now, Kingston. Love to have McMaster involved as well. The idea is that we're going to have a cohort, birth cohort, and just have a richer data collection around cannabis use. So the focus is really on collecting biospecimens, so blood, placental tissue, and breast milk as well. So it's a bit more intensive. We've had some pretty good response so far. It took a long time to set up the study to get approval, but we've recruited patients now, and we are adding a second site, so hopefully that will improve recruitment rates. We're targeting basically 100 participants, and we did stratify by cannabis use and not, and that's mainly to test the instruments because the team has, this is a sort of, getting ahead of myself again. The team has just sort of developed some really novel instruments on these cannabis diaries. So I think we heard in the other talks that some individuals make different decisions. They change the usage pattern. So we try to develop a flexible instrument that can capture that, so the patients can record what product they use, how many times they use it, if they know the CBD or THC content. And there's a sort of booklet that goes with that to explain it. Obviously, we don't know if participants will use this as well, but we have the blood sample to do a sort of quantification of biomarkers as well. And now I'll show you another exciting cohort. So this is the OAK cohort, Ottawa Kingston pregnancy cohort. So I went back. I always go back to the older cohorts to try and see if we can do anything there. But this is a cohort of 8,000 individuals from Ottawa and Kingston recruited between 2002 and 2009. And the amazing thing about the cohort is they had like 6,000 blood samples just stored. And when we had the funding available, we said, well, why don't we analyze it and we can look at cannabis biomarkers. Interestingly, they didn't ask if participants use cannabis. So at the time, they weren't sort of thinking about that. It's an interesting cohort. It's sort of, it has a particularly higher socioeconomic profile, I would say, compared to other ones. There's like 75% were in college educated and predominantly white Caucasian, like almost 88%. So not a very representative in that sense, but good data over time. And with the stored samples, we were able to quantify a panel of cannabinoid metabolites. So obviously THC and then some of the primary metabolites. We looked at cotinine as well to sort of validate against the tobacco that's reported in the cohort. And I think I didn't really know what to expect. We found a prevalence of like 10% of THC use, so that was pretty interesting, and it was higher for some of the different metabolites. I just plotted a few of them here. So it's something like around 10 to 20% of participants had some some metabolite prevalence. And then the next thing I'm working on is just sort of looking at the socioeconomic status distribution of cotinine and the cannabinoid markers. So cotinine sort of had this really striking inverse gradient, which is kind of what I was expecting. But then the cannabinoid markers were a mixed bag. It was more sort of flat or even a small uptick. So higher prevalence of those markers in the highest income groups for THC-A and THC-V. So yeah, just to kind of summarize some of the things we're doing. So cannabis use is definitely increasing, and in pregnant individuals as well. So we see it general population and pregnant individuals. We don't have the best data on how many pregnant individuals are using, and we do think that the use is very much socially patterned. So that's also important to recognize because that affects how the outcomes can be interpreted. So we do have associations with adverse outcomes, again, with the caveats of exposure measurement and socioeconomic status confounding. But there could be important prenatal cannabis exposure implications for neurodevelopment. Can't be too conclusive with just the population studies, but a lot of the animal data are kind of coming out as well. So that's really important, and we sort of borrow from those designs. But the epidemiological evidence is a bit uncertain. We're trying to make progress through different lines, approaching it from different angles. And yeah, I had a few delays, I think, to the research with the linkages. I thought it would be a lot smoother to kind of get that going, but you have to respect the processes to get the data vetted for privacy reasons. But fortunate that we have quite a few rich repositories, and we're using them to the best we can. And we'll see if the Qubit study kind of takes off. Happy to involve more centers and sites if there's interest. And a huge thank you to my team. We have a couple sites. We have a site for Qubit on Born Ontario. There's a page on cannabis with a few things from the Born data as well. And happy to take questions at this point. Thank you. Go. Yeah, go for it. Yeah.
It seemed like one of the most robust associations neurobehaviorally was the link with autism.
Yes.
And I'm curious if you have any sense for what the mechanisms for conferring that risk are.
Yeah, so that's a good point. So for the autism, it was a couple things. I mean, I think also the way that we identify the outcomes, so it's not the best data, right? It's not a diagnosis, but we use the OHIP data and some other things to look for codes related to autism, and they have a few more validated algorithms for that. They're not perfect, so that was kind of the primary outcome. And I think that there were a few other papers that sort of made a suggestion, but I hadn't seen that established before. So, but the association was pretty robust to an array of sensitivity analyses.
Yeah, as a follow-up, what stood out to me was that it seemed like the association was the least affected after you added in the confounders, whereas the association with ADHD got a lot smaller. Could you comment on the difference between those two crude estimates versus
Sure.
adjusted estimates?
Yes, so because I hypothesized that some of the effect is coming from socioeconomic status, then having those controls, and then we did a stratification as well by type of substance use. So we just restricted to cannabis reported only, and that also kind of maintained a similar effect. So it was interesting that the other conditions attenuated in a greater degree than autism. Yeah, thank you.
Excellent, very exciting work. I just want to build on that. Speaking about the autism stuff, my past work was in SSRIs in pregnancy, and trying to convince moms who need to take them to take them.
Right.
So it's interesting because there's some autism work that came out a few years ago saying SSRIs in pregnancy are associated with autism. But now there's some newer studies that actually show paternal SSRI use is associated with autism
Right.
and paternal psychopathology. So it builds on that same other graphs you were showing about the associations between paternal cannabis use.
Right.
And is the cannabis use or the SSRI use really just a proxy for more severe anxiety or depression? And then I just wanted to ask, did you have data on moms, diagnosis of depression or anxiety or SSRI use per se?
Yeah. So thank you. That's a really good point. So I guess I'll answer the last part first. In Born, we did have there's a medication field, so we can look at SSRI, and we did that in the paper on Born with prenatal, the perinatal outcomes, so we control for that. And then in the ICES, we looked at codes for maternal sort of mental health. I mean, again, it does have limitations, but we try to account for that in some ways. And autism, I think it may be a sort of a catch-all thing too. So because there's a lot of studies showing various things associated with autism, so it's hard to know what the causal mechanism is. But we tried a few creative ways of adjusting, and it stayed associated.
Yeah, there were recent data showing that C-sections and epidurals are both associated with
Right.
having autism. So everything causes autism.
Yeah, everything. Yeah. I mean, I think it's a limitation of the way, but it's a kind of an outcome that we go to a little bit because there is a specific code. So you can say, okay, well, that's ICD code. But some of the other things like the ADHD and stuff, we use medication for Ritalin and things there's other ways to support that, but it's all imperfect, sort of roundabout way.
Hi, I'm Eliane Ratcliffe from
Hi,
here.
how are
Hi,
you?
thank you for the talk and
Thank
also
you.
for those papers, which I think for a lot of us have been really influential and
Thank
that
you.
proof of concept for even biomedical research. So thank you. The question I have, I can tell going forward you're going to look at CBD, but just because we've been talking about it so much,
Yes.
some of the database work you have, would you be able to go back and look at the CBD? It would be helpful for proof of concept.
Yeah, I would try that. Yes, but I'm not sure what we can do with some of the things that's just reported. But going forward, we're going to try to partition if we can by CBD. And I don't know if there's anything, maybe Dan, if you can show with a blood sample, like if it's CBD or the source of it, but yeah. So it's a little bit tricky, but yeah, we're trying with the Cupid to have a really flexible way of capturing the use and then frequency and things as well. One thing I forgot to mention about ALSPAC is they had a separate questionnaire for each trimester, so we can kind of look like within the trimesters, is there change in use pattern? But theirs was also limited to just did you use cannabis and how many times per week, but not showing sort of like what product or anything like that. Thank you.
Hi, my name is Sam Newmark. I'm a McMaster alumni and current student at University of Toronto in grad school. Amazing talk, thank you very much. And you actually just alluded to it there about frequency. I was curious for the upcoming prospective study, is it just goal just to use the journal, or really how are you trying to determine and measure the frequency of use throughout pregnancy?
Okay.
Because I know it's very
it's tricky. Yeah. So with the cohort, I mean, it's kind of because it's a pilot study where we added a few kind of, I guess, data collection mechanisms that we may not keep them, but we basically have a survey, and there's a couple that will be introduced during pregnancy. I think 3 plus at the visit for delivery. And then there's the diary, which kind of complements that. So the participant can do the diaries and then just hand them in, and we'll have that data. And then we also have the surveys, which ask more specifically, like, did you use cannabis, how many times, and which products and things. So they kind of complement. And I think there was a concern that the diary may be too intensive on the participant. So we don't know, like at the end of the day, we have to kind of evaluate how well that sort of, is completed and if we can use it or not. But Yeah,
No,
thank you.
it'll be very interesting to see those results because we know cannabis use is not binary at all. You know,
Right.
daily use is very different from yearly use or monthly use. So
Right.
Thank you.
Exactly. Yeah. Thank you. Great. Thank you. Thanks so much.
So we're now at the close. So thanks everyone who attended, both in person and virtually, for making this a success. We had over 200 registrants, so I think that speaks to the interest in this topic. Many thanks to the speakers that came and shared the results of their work and have given us a lot to think about. I was going to say and a lot of opportunities for collaboration, but it seems as if many of you are already collaborating, so that's good to see, and I'm sure there's going to be future collaborations that come from this. Many thanks to Alan Fine and his team that got this great venue, organized an event very quickly, and made sure that there was a lot of supports and catering to sort of make it a comfortable event. And just to sort of briefly sum up what we've heard today, really interesting material. The idea that perhaps CBD has more important harms on the developing fetus that we maybe were aware of. The idea that there is increasing use amongst pregnant women of cannabis and cannabis products. The important idea that we have to avoid stigmatizing. We have to look for ways to engage people in respectful discussions, to understand the benefits that they perceive, to try to give them better information. We heard from a number of the speakers that there's a compelling interest, both amongst clinicians and from women, to understand more about the potential harms, that they're interested in perhaps mitigating these risks if they had better information. Compelling need for future research in these areas. I heard from a couple of the speakers this very interesting concept that there might be ways to actually provide rescue therapy, whether it's supplementing the diet or providing aspirin during pregnancy, that might help attenuate some of the potential harms that are going on in cases in which women make the decision that they still perceive greater benefits to use of cannabis in some capacity during pregnancy. So a huge amount to be done, but obviously a huge appetite, an incredibly important area. And I certainly look forward to perhaps having a similar event to this one in the future so that we can bring people back to talk about all the advancements that have been made. So again, a really interesting area, critical area of study, and one in which new research clearly has the potential to have a massive impact in terms of practice, education to patients, and helping women that are pregnant to make better informed decisions about what they wish to do during the course of their pregnancy and potential use of cannabis. So thank you so much for your attendance, for coming today. I encourage everyone to take a final look at the posters before they go. They're going to provide additional information that will complement what you've heard here today. And thank you so much for coming. Thanks.